Again, I will revise you. Columnar septum, first part, membranous septum, second part, and septum proper. It consists of perpendicular plate of ethmoid, vomer bone, and septal cartilage. Okay. Then little's area. It is important to know little's area in this regard of nasal septum, because anterior inferior part of nasal septum there is little's area which consists of 4 arteries anastomosis, which are 4 arteries: spinopalatine artery, greater palatine artery, ethmoidal artery, and superior labile artery septal branch. Okay. Again, there is revision. Nasal septum consists of 3 parts we have seen earlier. One, columnar septum. It is important for the incisional or operative purpose. Membranous septum is also clinically important, and afterwards septum proper is also clinically important. We will talk into later about these parts in the operative procedure. Septum proper consists of perpendicular plate of ethmoid, vomer bone, and large septal cartilage. Little's area, anastomosis of 4 arteries: anterior ethmoidal artery, spinopalatine artery, greater palatine artery, and septal branch of superior labile artery. Okay. Then next, deviated nasal septum. Deviation of the central wall which separates the 2 halves of nasal cavities in same way of the from the midline. It is very common. We will see the causes of deviated nasal septum. It requires treatment only if it produces symptoms. Means sometimes deviated nasal septum is present, but that type of deviation not produce that much like of symptoms. So initially deviated nasal septum is asymptomatic or mild conditions. There is no symptom. If there is symptom or complicated situations are there, then and then only we have to treat deviated nasal septum. Okay. Etiology. First of all, trauma is the main cause of DNS. When students are playing, sometimes in boxing or in playground, there is a trauma on the nose. Then nasal septum, which is fixed into vomerian groove, then it will be displaced or displaced. Then trauma is the main cause for the displacement of nasal septum or deviated nasal septum. Then second, developmental error or congenital. When congenitally or development of nasal septum is happened, at that time some type of deviation or deviated nasal septum is present in that condition. Developmental error, high arched palate. You can imagine when high arc palate is more curved or more convex towards the nasal septum, then nasal septum gets deviated. Okay, high arched palate. Then some other reasons causes tumor, mass or polyp in the nose and hereditary. Okay. Then we will move forward towards the types of deviated nasal septum. 5. There are 5 types of nasal septum. You can see in this picture: C-shaped deviation, S-shaped deviation, anterior dislocation, nasal spur, and thickening. These are 5 types of deviated nasal septum. C-shaped deviation, S-shaped deviation means C-shape. You can see in this image C-shaped deviation, S-shaped deviation, then anterior or caudal dislocation. This is caudal end or columellar end, in which the displacement of nasal septum in the right or left nasal cavity, you can say it as anterior or caudal dislocation. Then septal spur. Septal spur is developmental actually or traumatic actually, in which we can see more oftenly headache is occurs. And septal thickening, it is due to bleeding or complicated situation. Then we will see in details C-shaped deviation, simple curve to one side. Compensatory turbinate hypertrophy is seen in the C-shaped deviation because one side of nasal cavity is completely blocked and another side is functioning more or compensate other side of nasal cavity. So nasal turbinates work extra and hence compensatory turbinate hypertrophy is seen in C-shaped deviation. S-shaped deviation, bilateral nasal obstruction is there, anterior or caudal dislocation, dislocated one of the nasal chamber. It is either in left or either in right. Septal spur, shelf-like projection or osteocartilaginous junction leads to headache and epistaxis. When septal spur is more and it will stretch the mucoperichondrial or mucoperiosteal flap, then some of the capillaries will break and epistaxis or nasal bleeding comes from the nose. Then septal thickening due to hematoma or other causes. Clinical manifestations means signs and symptoms. We will see symptoms first. Initially, DNS is asymptomatic, as I can said it earlier. Nasal obstruction is the main symptoms. We can say it as cardinal symptom of deviated nasal septum, nasal obstruction or blocking of nose. Nasal discharge when there is a turbinate hypertrophy, when there is a deviated nasal septum, it will leads to rhinitis or it will leads to nasal discharge. Headache, we have seen that earlier in septal spur type of deviation, headache is main symptom. Sinusitis, when there is deviation, there is inflammation, there is rhinitis, there is a blocking of opening of sinuses, and there is pathophysiology of sinusitis. Epistaxis, if there is capillaries break due to stretching of mucoperichondrial flap or mucoperiosteal flap due to septal spur or deviation. Middle ear infections, when rhinitis occurs, it will go to the middle ear cavity through eustachian tube. Middle ear infections, in which we can see the symptoms like fullness in ear, earache, ear discharge. Okay, anosmia. Sometimes nasal mucosa terminates. Different types of inflammations are occurred due to deviated nasal septum, and recurrent inflammation, recurrent attacks of URTI will leads into anosmia. Deformity of external nose means, is there any trauma, is there any developmental error? Then symptom like deformity of external nose we can see. Then symptoms, after symptoms we will move forward towards the signs. What are the signs? deviated nasal septum, nasal mucosa congestion, turbinate hypertrophy, especially in C-shaped deviation, there is compensatory turbinate hypertrophy, sometimes sinus tenderness, sometimes ear congestion, EAC congestion, tympanic membrane retracted because of negative pressure in the middle ear cavity, and cone of light lusterless. Normally, cone of light present in the anterior inferior quadrant. When middle ear gets inflamed, then cone of light is lusterless, and afterwards middle ear cavity or middle ear gets infected, then cone of light is upset, will upset. Diagnostic examination, what are the or which is the diagnostic examination or examination procedure for the diagnosing deviated nasal septum, in which we will see anterior rhinoscopy. Simply tilt the nose and see the deviated nasal septum by focusing light source. Otherwise, insert thudicum nasal speculum and see the nasal structures in light source. That is DNS. You can see congestion, you can see hypertrophy, etc. What are the complications for the deviated nasal septum? Recurrent sinusitis, as we can see it earlier, middle ear infections through eustachian tube, mouth breathing, atrophic rhinitis. Yes. Then treatment. Initially asymptomatic, there is no treatment for asymptomatic deviated nasal septum. If mildly symptomatic, then medical treatment with local and systemic nasal decongestion drops. Grossly symptomatic, then it have to be needed surgery like SMR or septoplasty. What are the medicinal treatment? What is the medicinal treatment of DNS? Ayurvedic. It is no use if there is highly indication for surgery, but sometimes it mildly symptomatic, then we can use it. Some Ayurvedic treatment and allopathic treatment is there. Lakshmi Vilas Ras 250 mg, Tribhuvan Kirti Ras, Mahasudarshan Ganvati, then Sitopaladi Churna 1 gram, Eshtimadhu Churna 1 gram, Tunkan Churn 125 milligram with honey sartan 3 times per day. Okay. Shirovirecham Nasya with Anutel or Shadbindu Tel if there is compensatory or bilateral turbinate hypertrophy. Due to turbinate hypertrophy, nasal obstruction is more, then we will follow the Shirovirecham Nasya with Anutel Nasya or Shadbindu Tel Nasya. Then modern treatment, antihistaminics use, antipyretics with analgesic, antibiotics for the infection, nasal decongestion drops. SOS means if there is high obstruction rate, then you can use nasal obstruction for the relief of nasal obstruction. Then surgical treatment of DNS, in which two procedures are important: submucosal resection and septoplasty. Nowadays, recent advanced surgical procedure is submucosal resection. In some cases, there is no option, like below 17 years, complications are more, then we will go to the septoplasty. Otherwise, SMR is the most advanced recent surgical procedure. Goals of surgery. What are the goals? Exposure of the pathology portion of septum, removal or reconstruction of defective portions, preserve nasal mucosa and lining, prevent external deformity of patient. Okay, then we can see the 10 points of any operative procedure as like deviated nasal septum, tonsillectomy, and so many procedures in the ENT. We will see the each and every procedure in this regard of these 10 points. What are the or which are the 10 points of surgical procedures? Introduction or definition of that surgical procedure, indication of that procedure, contraindications of that procedure, instruments of that procedure, anesthesia, which anesthesia used for these procedures, position of that procedure, preoperative, operative, postoperative complications. These are 10 points you have to keep in mind regarding the all surgical procedures. Not for this submucosal resection, you can write these 10 points in the tonsillectomy, proof puncture, mastoidectomy, all the ENT procedures. Then we will see one by one. SMR, submucosal resection introduction. Submucosal resection is radical surgical procedure in which total nasal septum is removed except dorsal and columnar part. We will see it later. 1 centimeter width by dorsal and columnar part is left. Indications: severe nasal obstruction is there. If there is a nasal obstruction severe, then we will go to nasal submucosal resection. Recurrent headache in septal spur, recurrent rhinitis, recurrent sinusitis, recurrent epistaxis, recurrent otitis media, and cosmetic corrections in septorhinoplasty. These are the indications for SMR submucosal resection. Then what are the contraindications? Patients below 17 years of age. In these cases, we will go to the septoplasty. Acute respiratory tract infection. If there is acute respiratory tract infection, there is hyperemia or inflammatory conditions are there in which we cannot do the submucosal resection. Bleeding disorders like hemophilia, purpura, aplastic anemia, like these. Systemic disorders like diabetes or hypertension if it is uncontrolled. Anesthesia, especially local anesthesia with sedation. SMR done under local anesthesia with sedation, in which anesthesia is done by xylocaine 2% with adrenaline 1 as to 50,000 units. Sedation, there is a combination of 10 cc solution is used for sedation in the submucosal resection or endonasal DCR or septoplasty, in which 1 cc fortwin, 1 cc compost or diazepam, and 8 cc distilled water. In the 10 cc solution, this is the combination: 1 cc fortwin, 1 cc compost, and 8 cc distilled water. During the operative procedure, we can push 3 cc to 5 cc solution for the sedation of the patient. Then if there is pain, severe pain, and patient is not bearable, then we can push it again for 2 cc or 3 cc. Okay. Then position, reclining position with head end of the table raised. Okay. Then instruments, what are the instruments? Which are the instruments used in the submucosal resection? First, Thudicum nasal speculum is used for nasal packing, anterior nasal packing before the procedure. Nasal packing forceps is used for nasal packing. Then scalpel with bipendal with surgical blade number 15. Then perichondrial or periosteal flap elevator then Killian's forceps, then Lux forceps, then gog and hammer, Vicryl catgut or absorbable sutures, and suction machine. These are the instruments used in this procedure. One by one, step by step, we can see these instruments in the procedure. Okay. Then what are the measures in preoperative? NBM, it is highly indicated for the operative procedures if there is general anesthesia or if there is local anesthesia. Before operative, you have to keep the 6 to 8 hours NBM. Anterior nasal packing before 1 hour of surgery with 4% topical xylocaine and adrenaline ampoules. Or you can use nasal decongestion drop for 10 to 15 minutes interval before 1 or 2 hours before the surgery. Xylocaine sensitivity test, injection TT, and IV point if needed. Then operative. What are the steps of operation or which are the steps of operation? First, infiltration of nasal septum means with the help of adrenaline, xylocaine 2% and adrenaline 1 as to 50,000 unit, we infiltrate the nasal septum. The blanching will be seen on the nasal septum or turbinates or nasal mucosa. Then we can confirm it as infiltrated. Okay. First step is infiltration of nasal septum or surrounding procedures, surrounding sites of the operative procedure. First incision. In the SMR, we have to take 2 incisions. First incision, curvilinear incision on mucoperichondrial flap of left side. Generally, surgeons are more comfortable with patients' right side. So it is better to take the incision on left side, and most oftenly surgeons will prefer the left side of the deviated. Then elevation of mucoperichondrial flap and mucoperiosteal flap. Nasal mucosa. When nasal mucosa runs over the nasal septum, then we will say it as mucoperichondrial flap and mucoperiosteal flap. When nasal mucosa and skin covers the cartilaginous part of nasal septum, then we can say it as mucoperichondrial flap. Then nasal mucosa runs over the bony part of nasal septum, then we can say it as mucoperiosteal flap. The mucoperichondrial flap and mucoperiosteal flap on both sides of the nasal septum. Okay, then the same side of first incision, after first incision, with the help of perichondrial flap elevator. First incision is taken by surgical blade number 15. Then elevation of mucoperichondrial flap and mucoperiosteal flap with the help of perichondrial flap elevator. You can use it for the elevation of flaps from same side. Then second incision. Site of second incision is on septal cartilage just behind the first incision. Okay, first incision on columnar end, just behind the columnar end, and second incision is just behind the first incision. First incision site is mucoperichondrial flap and second incision site is septal cartilage. Second incision on septal cartilage just behind the first incision. Then same elevation of mucoperichondrial flap and mucoperial osteal flap on opposite side. You can imagine the steps of operation. First, we have to infiltrate the nasal septum or surrounding structures. First incision is taken with the help of surgical blade number 15 on the mucoperichondrial flap just behind the caudal end. Then, with the help of perichondrial flap elevator, we can elevate the mucoperichondrial flap and mucoperiosteal flap on same side. Then, after elevation, we use again the surgical blade number 15 and incise the septal cartilage just behind the first incision. You can use 1 centimeter distance. Then opposite side elevation of mucoperichondrial flap and mucoperiosteal flap. Then removal of cartilaginous and bony part. After elevation of both side of mucoperichondrial flap and mucoperiosteal flap, then we have to insert Killian's forceps or long bladed nasal speculum on both side of nasal septum or the cavity in between two flaps of nasal cavity or nasal septum. Okay, when we introduce the Killian's forceps, then nasal septum is remains into the midline or middle to the blades of Killian's forceps. Okay, then we have to catch it by lux forceps. Cartilaginous part or bony part is removed irregularly by the lux forceps. Then we have to regularize the cartilaginous or bony part of nasal septum with the help of gog and hammer. Okay, means removal of cartilaginous and bony part. Cartilage can be removed with lux forceps and bony spur is removed using gog and hammer. Okay. Preserve a strip of 1 centimeter wide cartilage along the dorsal and caudal border. As I said earlier, 1 centimeter nasal septum on the dorsal side and columnar side. You have to preserve it because saddle nose deformity, dropping of the nasal septum is seen in the excessive resection of the nasal septum. So you have to preserve a strip of 1 centimeter cartilage along the dorsal part and caudal. Okay. Then when it will be finished, then you have to suck or you have to use the suction machine for the bleeding which is at the end of nasal flaps or in the cavity of nasal flaps. You have to suck by the suction machine and clear it, because if there is some sort of bleeding left behind, then it will lead to complication like bleeding, hematoma, and likewise. So you have to clear the operative site or flap cavities with the help of suction machine. Okay, then next step is suturing or stitching or closing out that wound. One or two or three stitches done for the closing of that wound or that incision. Okay, afterwards we can do the nasal packing with the help of antiseptic or anti-infective or antibiotic cream like Sopratex, Sopramycin. Antiseptic cream is used for instant or immediate post-operative nasal packing, which is to be removed after 24, or some surgeons used it for 48 hours. Okay, so we will revise it once again because operative procedure or steps of operation is very much important. First step is infiltration of nasal septum. When patient is on operation table, then you have to prepare other surgical procedures and then move towards the first step of SMR. It is infiltration of nasal septum with the help of Xylocaine 2% with adrenaline 1 has to 50,000. You can infiltrate the nasal septum, operative site, and somehow turbinates. Then first incision. You have to take first incision on the mucoperichondrial flap just behind the caudal end, curvilinear incision on mucoperichondrial flap on left side. Then you have to mop it with the gauze piece or suction machine. Then elevation of mucoperichondrial flap and mucoperiosteal flap on same side with the help of mucoperichondrial flap elevator. Then you have to take second incision on septal cartilage just behind the first incision or 1 centimeter behind the first incision with the help of surgical blade number 15. Then again elevation of mucoperichondrial flap and mucoperiosteal flap on opposite side. Okay, then both flaps are separated from the nasal septum. Then you have to use the lux forceps and gog and hammer. With the help of lux forceps, you can remove the deviated cartilaginous part, and with the help of gog and hammer, you will remove the bony spur and regularize it. Okay, margins are regularized. Preserve a strip of 1 centimeter. If there is excessive resection, then saddle nose or dropping of nasal septum will occur. Then clean the septal flap cavity by the suction machine. Whole blood from the operative site or flap cavity has to remove by suction machine. Then end of the procedure is suturing, stitching or closing. With the help of catgut or vicryl, you can suture it or stitch it or close it. Okay, after that closing, you can see the post nasal bleeding. Confirmation of the bleeding from operative site, you can see the post nasal bleeding immediately after closing or suturing. You must to see post nasal bleeding. With the help of tongue depressor, you can see the light source or headlight or head light, you can use it for the seeing of post nasal bleeding, and nasal packing with the help of antiseptic cream like Sopradex or Sopramycin. Okay, then you can see in this picture first incision, Killian's incision, then mucoperitoneal flap is elevated with the help of mucoperitoneal elevator, flap elevator, Killian's forceps or long bladed nasal speculum. In these two blades, you can keep the nasal septum, this nasal septum in the midline and catch by the lux forceps. Then cartilage and bone remove from this area or deviated part of the area 1 centimeter, that is dorsal, and this is caudal 1 centimeter, preserve it. Okay, then post-operative, what are the measures in post-operative care? First, NBM 6 to 8 hours, soft diet for 2 days. Due to hard diet or hard solid material, there is dental and temporomandibular joint. Due to that site near to the temporomandibular joint and dental, so there is a pain in operative site. So soft diet is followed. Antibiotics, because nasal packing for 1 or 2 days will remain. So there is chances of sinusitis or infection. So we can use antibiotics for 5 days or 7 days. Analgesic for painkiller, antacids for the supporting. Due to operative or due to medicines or due to injections, there is hyperacidity, so you can use antacids. And last, nasal packs will remove or after 48 or 24 hours, followed by nasal decongestion drop and steam inhalation. Some crusts are seen after nasal pack removal. For that, you have to continue steam inhalation and nasal decongestion drop for 4 to 5 days. Enough. After that, follow after 1 week, means some crust, some adhesions in between the nasal septum or operative site and lateral wall of nose, then you have to remove it. Some surgeons advise Sopradex ointment cream for 10 days, 15 days, and after 1 week, or if there is again obstructive pathology due to adhesions, due to cream, or due to some sort of crust, then follow after 1 week, 2 week regularly for the removal of crust, adhesions, and obstructive pathologies. Okay. Then complications. What are the complications? As I said earlier, too many complications from excessive resection or bleeding left behind in the cavity of operative or flap cavities. Bleeding. First and important complication is bleeding. If there is a bleeding, as I said earlier, with the help of suction machine, you have to clear the cavity of operative, and afterwards you have to see the post nasal bleeding with the help of tongue depressor and light source. So there is no bleeding. Afterwards, you will finish the operative procedure. So you have to prevent the bleeding at operative site. Then septal hematoma, if there is bleeding, it will leads into septal hematoma. If septal hematoma is there, it will lead into septal abscess, and if there is septal abscess, it will leads into septal perforation. Okay, bleeding, bleeding will leads into septal hematoma. Septal hematoma leads into septal abscess, and septal abscess vidradhi. Like beyond the line, I will talk about cholesteatoma. Some procedures like cholesteatoma and septal abscess will leads into perforation, septal perforation, and in that case, cholesteatoma, it will leads into meninges or CSF due to abscess, due to vidradhi, erosion, erosion of surrounding structures, septal perforation. Then suprative depression or depression of bridge, excessive resection, or if there is excessive resection and you not able to keep or not able to keep or not able to keep the 1 centimeter width for the dorsal and columnar part of the nasal septum, then suprative depression and depression of bridge is or will happen. Retraction of columella and persistence of deviation. In these cases, retraction of columella or persistence of deviation, you have to revise the surgery. Means revision of surgery is important. So here there is finish of SMR, means submucosal resection procedure. What are the difference between SMR and septoplasty? We are using nowadays only SMR. In some cases, we are using septoplasty. If child is coming with uh, various types of complications or middle ear infection, persistent middle ear infection, persistent sinusitis, likewise, then we have to follow this septoplasty. But before the 17 years, we more oftenly prevent or stop the operative procedure for the nasal septum deviation. We oftenly use nasal septum surgery like SMR only. Then what are the difference between SMR and septoplasty? We studied whole submucosal resection in the 10 surgical points. I am not going to detail in the septoplasty as SMR in detail, but I can say the difference between submucosal resection and septoplasty. So you will get knowledge about these two different procedures regarding the deviated nasal septum. Okay, then we can see the difference submucosal resection and septoplasty. First difference, submucosal resection is a radical surgery and septoplasty is conservative surgery. Submucosal resection is not done in children. Septoplasty can be done in children. Submucosal resection in the SMR, you incise with Killian's incision, and in septoplasty, you can incise with freeze incision. In submucosal resection, flap elevated on both sides. In septoplasty, flap elevated concave side only, or one side only, or deviated side only. In submucosal resection, most of cartilage is removed. In septoplasty, most of cartilage is preserved. Okay. Submucosal resection, perforation chances are higher, perforation chances are rare in septoplasty. Submucosal resection, revision of surgery is difficult due to resection, total resection of cartilaginous and septal part or bony part. Revision of surgery is easier because some part or only deviated part is removed. Okay. You can see total slide. This is the difference between submucosal resection and septoplasty. In the septoplasty, all the measures like preoperative, postoperative and other measures are same as submucosal resection. Only steps of operation or operative procedures are different. Okay. Thank you very much. Today we studied detail about deviated nasal septum and its surgical management with some part of medicinal management, in which we studied the nasal septum, its anatomy, because anatomy is important for the application in the operative procedure. So we have to study the nasal septum first, and then afterwards we studied deviated nasal septum in detail, like etiology, then types, then signs, then symptoms, complication of deviated nasal septum, and afterwards we have been seeing that the operative procedure or surgical management of deviated nasal septum, means SMR and septoplasty. Thank you very much for kindly and patient listening. Thank you.